Welcome to panel 2. We're not taking a break here, we're just going to keep on going. This wonderful panel is going to continue the exploration of some new approaches to reducing unplanned pregnancy. My name is Sarah Brown, and 4 colleagues to my left join me this morning. Mark Edwards is the co-founder and co-CEO of Upstream USA that you've heard so much about this morning. Ian Rode, next to him, is the CEO of the Public Prep Network of charter schools in the New York City area. Ginny Ehrlich, next to him, is the CEO of Power to Decide. And Dr. Janice Tildon-Burton is a leading OBGYN in Delaware. Now, I am not going to go through their wonderful resumes because I do believe you have them. Yes?
Can you bring your microphone way closer?
Much closer. Is that better?
Yes.
Thank you, Richard. I'm not going to go through their wonderful biographical statements or in your materials, but suffice it to say these are all rock stars, and we are thrilled to have them all here together. The theme of this panel, and indeed this entire meeting really, is showcasing new approaches to providing high-quality family planning. Now, as an old warhorse in this field, I must say that it's about time. In 1995, when Belle Sawhill and I and many other people in this room began to put together the National Campaign to Prevent Teen Pregnancy, which is now Power to Decide, led by Ginny Ehrlich, I went on what I called a listening and learning tour to try and see what was fresh and new in the pregnancy planning and prevention sector. I had last worked in family planning and in community programs in the late 60s and early 70s in several different states. And I was sure that by the mid-1990s, there would be many, many new practices and programs and models of clinic flow and provider training, even new materials that would be inspirational, wonderful, and that our group should probably disseminate, and others as well. In truth, though, I returned home from my travels unimpressed and even puzzled. I remember saying to a few colleagues that next to nothing seemed to have changed on the ground in almost 30 years, that is, from the late 60s and 70s, and that if ever there was a sector that needed a little bit of reinvention and reimagining, maybe even disruption, family planning was it. The good news, as this event has already showcased, is that the picture today is significantly different. There are now numerous efforts underway doing wonderful things in family planning, some at the system level, some at the personal one-on-one level, some in billing offices, and everything in between. So without further delay, let's hear some more about what's current in choice. And we begin with Mark Edwards. And I'm going to allow each person either sit down or stand up as they choose.
Thank you, Sarah. Thank you very much. And I want to start by thanking Belle and Ron and Richard for hosting this event. I think you have been on the forefront of pushing us all about how to think about opportunity in this country, and I'm just grateful for that. Secretary Weissman, of course, Carol Rattay from Delaware, Dr. Rattay, Janice Tildon-Burton, who I'm thrilled is here, really a leading provider from Delaware, who just can take this sort of conceptual conversation and bring it quite real, down to the real experiences of real patients. Sarah Brown, of course, for introducing me to the whole history of family planning, and Governor Markell. Thank you for your leadership in this important area. You've heard a lot today about what Upstream does, and so I won't spend a lot of time rehashing all of that. At its simplest, all we're really trying to do is ensure that women are empowered to choose the contraceptive methods of their choice. We're really trying to bring the healthcare practice to best-in-class care. And I also want to thank all of my Upstream colleagues who are here today, here as well as the 100-plus Upstreamers around the country. We're really excited about some of the work that's been happening in Delaware. When we came to Delaware, quite frankly, we saw a mixed healthcare landscape. There were health providers who were only offering their patients the pill, patch, and ring. They weren't offering them the most effective methods. There are others that were doing a better job. And people often ask, what are the issues? Why aren't people being offered the full range of methods? And what we find is that it's not just about training providers. Of course, if providers can't place and remove the full range of methods, that can't happen. But if you don't stock the methods, if you don't bill and code for them properly, if you can't make your workflow work so that women can come in and really being offered the full range of methods, they won't be able to get them in a single visit. And being able to get those methods in a single visit is really the key thing here. What we know is that if it requires 2 or 3 visits, which for many places is really the standard of care, women won't come back. And what we also know is that, for example, if you don't stock the methods, and by definition it's going to require multiple visits. And so what I think we found, which is quite interesting, is that while the policy changes are critical, and we've heard a lot about those policy changes, as Dr. Chirac said, it's not just about the policy changes. We have to actually change practice. And so there are many times where we found that the policy was saying women should get all these methods. They should be able to have great counseling and get all those methods, but the practice was simply not translating into that. And that's really the place that Upstream is trying to work in. As an organization, we're thrilled about some of the progress in Delaware. We're now expanding our work to other states so that we can reach health centers that serve about 1 million women or more over the next several years. But I also want to acknowledge that our work takes place in a very important context, and that is the context of extraordinary oppression and reproductive coercion in this country. I want to thank Mara Gandel-Powers from the National Women's Law Center for raising that question in the very first panel. This is not just ancient history. This is ongoing today, that women and people of color around this country are being targeted for forced sterilization. And we are deeply, deeply aware of the context that we work in, which is one of the reasons that as an organization, we regularly survey patients to ensure that the experiences they're having are excellent experiences. Dr. Rattay spoke about what was happening in Delaware, that 99% of patients are saying that they were in charge of choosing their own methods. We also know that 98% plus are saying that they felt listened to in their contraceptive conversations, that 99% are saying they didn't feel pressured. We regularly do that because it's just a central foundational part of what it means to deliver best-in-class care. And we're grateful for women of color around this country who have held these issues up. They have every right to ask questions of organizations like ours and others to make sure that we're doing a good job, and we're grateful for their partnership. So we are very excited about how this work is taking place around the country, and at the end of the day, all we're trying to do is make sure that people have the education, the choice, and the access. It's really an equity issue. And if you take this out of reproductive health care for just a moment, I mean, imagine what the data show is that IUDs and implants are 20 times more effective at preventing unplanned pregnancy than the pill, patch, or ring. Imagine if there was a stent that was 20 times more effective than another stent, and we allowed a healthcare system that didn't make that stent available. It'd be an outrage. And that's really all we're trying to do here today, is to make sure that women have access, people have access to all methods of birth control with great patient-centered counseling so they can choose what really works best for them. So I'm thrilled that Dr. Janice Tildon-Burton is here because she's going to talk to us in Delaware about what is actually happening with real patients in her practice, and that's at the core of the work we're doing. I just want to emphasize one other thing that Dr. Rattay said, which is that at the end, we really are trying to ensure that all women have access to all methods. So in Delaware, someone asked a question earlier about what do we do about people who live not near a health center. We actually partnered with Uber to make sure that patients could get free rides to the health center of their choice as part of that work. We know that transportation is a huge barrier for many people. And so that's another aspect of trying to recognize that this is not just about what happens in the health center, it's also about what happens to get people there in the first place. So in the end, I think empowering women to choose when and if they become pregnant is really one of the most important things we can do. I think it's something that we all can get behind. And I'm excited about what this can mean for our country. Thank you.
Thank you, Mark. We now turn to Ian Rowe.
Good morning. Okay. Good morning. My name is Ian Rowe. It's a great honor to be here. Belle, thank you very much for the opportunity to speak. And I'm also proud to represent the world of public education and how we have to think differently about educating the next generation to think about how to navigate these issues and to get into a position to make the best decisions for their individual lives. These are some of our graduates. I do run Public Prep, which is the nation's first and oldest network of single-gender public charter schools in New York City. We have about 2,000 students across our 5 campuses in the heart of the South Bronx and the Lower East Side of Manhattan. About 90% of our students are from low-income communities, and nearly 100% are Black or Hispanic. We're very proud of the fact that our first cohort that started in girls prep way back in 2005 in kindergarten and first grade, they are now freshmen and sophomores at some of the finest colleges and universities in the country. So we're very proud of that. But we know that our kids face enormous challenges, and in New York City, the need for more great schools is huge. And so back in 2015 and 16, we were thinking about our growth, and we decided to make a decision to focus all of our growth in the Bronx, particularly in the South Bronx. And so we made a decision to move our headquarters from Tribeca in Manhattan to 148th Street in the heart of the South Bronx. And we decided to go on a walking tour to get to know the neighborhood. And on that walking tour, we saw a 27-foot baby blue Winnebago truck. And all these folks were excited to see this truck. And it turned out it had graffiti lettering on it. And the lettering said, "Who's your daddy?" And it was almost like the ice cream truck in terms of how excited people were to see it. It turned out that Who's Your Daddy is a mobile DNA testing center that charges low-income folks between $350 to $500 to answer questions such as, is she my sister? Could you be my father? And it was a really profound moment for me. It was an epiphany moment for me. Because the normalcy of that truck, the acceptance of that, made it clear to me that the environments in which our kids are being raised, there's a break that we have to effect in the world of public education if we want different outcomes for our kids. That led me on a journey to start doing research, particularly related to the non-marital birth rate, what has transpired in our country over the last 5 decades. As many of you know, there's an explosion in non-marital births from 5% in the 60s to now consistently about 40% of all births in the United States are outside of marriage. And that has had a profound impact on the family structures in which children are raised. Something we don't speak about, but I think it's very important that those of us, again, particularly in public education, think about not only the causes, but how do we stop this cycle from repeating in the first place. Just to give you a snapshot, in 2017, and I've particularly focused on women 24 and under, and by the way, it would be great to have the same data for men, but it's only tracked for women. But for women 24 and under, in the Black community, 9 out of 10 births are outside of marriage, which is a staggering number. And in sort of a depressing thing of how the racial achievement gap is closing, in the white community, it's 61%. And across all of these, 41% of women 24 and under who had a baby in 2017 were having their 2nd through their 8th child. So that has profound impacts for the ensuing family structures because you have large numbers of very young women raising very young children. So what do we do about that? And obviously, for many of you know, the emerging brain science and cognitive development, kids in these situations are at much higher risk of having adverse childhood experiences, which then severely impacts the learning foundation that happens even before our kids enter formal schooling. So we at Public Prep, we've thought a lot about this. What can we do both on the front end and the back end to address these issues? So we've created a concept called 18 to 18, where the first 18 is 18 months, which I'll describe to you, and the second 18 is 18 years. And we feel it's important that we are providing a model, hopefully that can be replicated by other public schools across the country, to both break the firewall on the front end of schooling. So we actually have now started a partnership with the Parent-Child Home Program, which is a 2-year home visiting program for the 18-month-old younger siblings of our current boys prep and girls prep scholars. So because they are guaranteed entry into our schools when they enter our lottery 2 or 3 years from now. Those kids will receive 2 years of home visits by an early learning specialist, 2 times per week, 30 minutes per visit. An early literacy specialist sits with the caregiver and her child, typically a single mom, to help that parent build their capacity to be the at-home reading coach. How do you reduce screen time? How do you create a library at home? How do you take advantage of walks to the local bodega as an opportunity to build vocabulary? We are very, very confident that that will have a huge impact on the levels of school readiness that we achieve for our kids. We also created a partnership with Sesame Workshop around pre-K, so we're now one of the largest providers of pre-K in New York City in terms of charter schools. But the key is that even before formal schooling begins, at 4 years old, we have a really well-integrated pre-K that's aligned with our elementary school. This is some data which shows that the readiness levels of kids who go through our pre-K is at 93% versus kids who've just come in straight into our lottery only at 23%. So again, all of these efforts around aligned early childhood education we think is really important. This is our Parent-Child Home Program, a picture of a parent with a caregiver. Each week, the parent or the caregiver gets a new book. So by the time the end of the 2 years, you've got a 100-book library. And we've just normalized education and literacy within the home. PCHP, which is now actually called Parent-Child Plus, they've just changed their name, has an incredible track record, longitudinal data about the positive impacts of kids who went through this kind of experience. Starting early, it's necessary but not sufficient. For us, we go through 8th grade, so what is it that we can do to help our graduating 8th graders really have an understanding of the series of life decisions that are most correlated to life success? Thanks to the work of Bell Sawhill, Ron Haskins, a few years ago I came across the data associated with the success sequence, which is the name of a series of decisions, education, full-time work, marriage, then children. The data shows, and it's descriptive, not prescriptive, but the data shows that when those series of decisions are made, somewhere between 94 to 97% of the time, you're going to land in the middle class or upper class or beyond. That's important information that our graduating 8th graders need to know. So we've made that a part of a codified class called Pathways to Power, which is to ensure that as our kids leave 8th grade and enter high school, college, and the first 4 years of young adulthood, they know the series of life decisions that more likely will lead to life success. And then just finally, I think in the same way we're talking about unplanned pregnancies, we do need to have the courage to talk about the ensuing family structure, non-marital birth rates, because that's all part of this discussion. Invest in district and early intervention, so we break what is typically a firewall between K-12 education and early childhood education. Teach the next generation about the series of life decisions most correlated to success. And then finally, actually measure academic outcomes, not only by the usual suspects of race, class, and gender, but also incorporate family structure, because I think we'd start to see that that's a factor that transcends many of these other elements. Thank you.
Thank you, Ian, so much. Our next speaker is Ginny Ehrlich, the head of Power to Decide.
Good morning, everybody. As we're getting my slides set up, I want to thank Belle, Ron, and Richard for the opportunity to be here. At Power to Decide, we work to ensure that all young people, no matter who they are or where they live, have the power to decide if, when, and under what circumstances to get pregnant and have a child. And we focus our work specifically on those most impacted by unplanned pregnancy, women of color and low-income women. We recognize that the inequities that still persist around rates of unplanned pregnancy are by and large systems inequities and not about the women themselves. And for that reason, we recognize that the work is very intersectional, and our piece of that work is really focused on leveling the playing field around good quality sexual health information, access to services, and agency and opportunity for women. And really the nexus between those is what really matters in terms of really having everything come together. Today, I'm going to talk about our digital online property called Bedsider. Bedsider really is an example and an emulation of all of these concepts of information, access, agency, and opportunity to come together. We launched Bedsider in 2011 to fill the voids that existed then and currently still exist in serving up relevant, resonant, and accurate information to young people, and specifically focused on young women from 18 to 29 years old. Bedsider works to ensure that women have and all people have access to quality sexual health information on their own terms, on their own timeline, and that they have access to knowing where to find services. They have access to user tools to use contraception effectively. We also have a series of provider tools and clinical education tools that are used in thousands of clinics across the country. So you might be asking, why are we talking about this in the new panel? And we're talking about this in the new panel because the magic of Bedsider is that we're constantly reinventing it. We're constantly making it so that the users drive content, and we're driving the needs through the users. We see it as an opportunity to provide sex education before, during, and after a clinic visit and outside of the classroom, on women's own terms and on their own timeline. We think of it as sex ed for the 21st century, and as you can see, it doesn't look like a typical DC website. It's a little edgier, a little catchier, and cuts through the noise and politics that we've been talking about today. We also know that Bedsider has impact, and it's worked. A randomized controlled trial study published in 2015 found that women who accessed Bedsider at least 4 times, by comparison to a control group, were less likely to have a pregnancy scare, less likely to have unprotected sex, less likely to report an unplanned pregnancy, and they were more likely to use a more effective method of contraception. Colleen Kay, who's one of the authors of that study, is in the room today. So Colleen, thanks for your work on this. So in the spirit of reinvention and our focus on health equity, we set out in 2017 to answer the question, can we ensure that Bedsider is serving those most impacted by unplanned pregnancy, young women of color and low-income young women? At the time, only about a third of the most engaged Bedsider users comprised of that population. So we decided to look at how we could optimize Bedsider to really serve the needs of women most impacted. We did ethnographic interviews with women and their girlfriends through girlfriend groups. We explored how they use their devices to access sexual health information, how they think about conversation or decisions about contraception in the context of their lives, how they talked with their girlfriends about these issues. And we learned a lot about it. We learned that by and large, and actually to a person of the women who were part of those ethnographic interviews, that they described some sort of sexual violence in their past. They didn't use the words, but they talked about the experiences. We discovered that they do plan, but they plan for the next day or the next hour because that's a luxury that they're working within. we discovered that they care about these issues, and because of their experiences, they were trying to figure out in their 20s, early 20s, how to navigate their relationships in a way that was healthy and a little different than maybe they'd navigated them in the past, because they all wanted to go forward and move forward in some direction. We identified 4 archetypes: stuck, looking for love, living in the now, and in control. And we shifted Bedsider from a functional perspective as well as a content perspective to really meet the needs of the young women, and really in ways that we hope resonated with these women. You see the content kind of emulated here. You got this. It might be, walking out the door. It might be getting to a class or going to work. But it was that sense of agency that was so important for these young women. We shifted the content to really talk about the sense of agency, next steps, not long-term planning, and we shifted the functionality of Bedsider so that short-form articles were more accessible for the short amount of time women had to really look up information, and we made it much more mobile-friendly. Today, 84% of Bedsider's traffic is mobile. That was not the case in 2011, so it really requires that new and reinvention. In 2018 alone, just to give you a sense of numbers, Bedsider had 7.3 million unique visits. And now 63% of the most engaged users for Bedsider are African American and Latina, and 23% are women whose incomes are below $50,000. So we saw some tremendous increased reach and impact for those most needing information through the development of this approach. We also found impact on knowledge, attitudes, and beliefs. We found statistically significant increases in knowledge, in behavioral intent amongst all users to use hormonal or LARC methods of contraception, statistically significant increases among African American new users to use hormonal or LARC methods of contraception, and statistically significant increases in intent to use LARC methods among women whose incomes were between $25,000 and $50,000 a year. We also found that they found it easier to find information and felt like they could find a method that was right for them. We found some good trend data related to improvements in Latina women intending to use hormonal or LARC methods, and among all users feeling more confident in talking about these issues with partners and really navigating those decisions. We constantly reinvent ourselves. We use these data. We use ongoing user data to do new content. Bedsider serves up 8 to 10 different new articles every week. That's because 18 to 29-year-olds refresh their phones about every 45 seconds. And so if we want to be relevant, we have to do that. We've talked a lot about access to contraception today, and what we're looking at now in terms of how we leverage the power of Bedsider's platform is to really look at contraceptive access. This map represents, before last week, what the contraceptive access looked like by county across the country. More than 19.5 million women live in what we call contraceptive deserts, or counties in which there's not reasonable access to the full range of contraceptive methods. Reasonable access being 1 clinic to 1,000 women eligible for publicly funded contraception. That's not okay. We know we need systemic solutions, policy solutions, and we're working hard alongside our sister organizations to make those happen. But this means that every day, those that you see in the yellow and pink parts of this map are trying to decide how they're going to use their transportation dollars. Are they going to go to work, or are they going to drive or transport themselves a long way to access basic health care? How are they going to pay for that extra child care if they already have children? How are they going to address unpaid time off if they don't have PTO? These are real trade-offs for real women. And so on to Bedsider, what we've launched is BC Benefits, a contraceptive access fund. A fund that will support the unreimbursed unrealized costs associated with accessing contraception. It's up and running in its first form, whereby we're able to offer telehealth prescriptions as well as prescription delivery for women whose incomes are at or below 250% of the poverty level for hormonal methods. By the end of the summer, we'll be adding transportation and support for unreimbursed costs for all methods. We see this as something that really addresses an immediate need and gives women what they need to make the decision that's right for them. And we're really excited about being able to add this to Bedsider as a next iteration in terms of what's new. So thank you very much.
Thank you, Jenny. That was wonderful. And our last speaker is, not last but not least, is Dr. Tildon-Burton. And I have seen her on video, but I've never seen her in the flesh. And I know her reputation precedes her. Thank you for being here.
Thank you so much. And thank you for inviting me. I said when I came in earlier, and I don't recall who I said it to, but I never thought I would be in the Brookings Institute. So I'll add that on my little Instagram and Twitter today as I go out. So I feel like there's a lot of pressure here. People, oh, you're going to hear from Janice Tildon-Burton. I'm like, I'm not all that. I'm a practicing obstetrician and gynecologist and have been for about 30 years. I've done a little bit of everything. I've been in solo practice. I've been a hospital generalist. I've been in a group practice. And so I have a breadth of understanding of what it is to be on the ground, and I'm still on the ground. I deliver babies still. I do general gynecology. So I'm considered a generalist because there's so many subspecialists now in my field. I deal with a wide, diverse population. So I have very young women. I have girls. My youngest patient is 11, and she has some menstrual problems. And so her pediatrician wasn't comfortable and had invited me to try to help with managing her. So that's my youngest. My oldest is 88. And I just got a call from her this past week to see if she should come in for an exam, to which I said, it really is up to you. At 88, I'll go by whatever you decide you need for me to do. And if you want to come in, I'll be happy to see you. She made an appointment. But the reason I'm here is because of the work that Upstream has done in the state of Delaware in conjunction with our governor and Dr. Rattay over at Health and Human Services. And it's been a fantastic journey, I think. Being in private practice, I can tell you, I try always, or have tried always, to give a breadth of information to patients when they come in. But as a realist, there's times when I just don't have enough time to do what I would consider an adequate job to give information to patients that need it. So this question that we now have in my electronic record, do you plan to become pregnant this year, has really forced everyone in the office to become engaged. And it helps me to help the patients, because once they've entered the office and they've checked in and they've filled out some information for us and we see that they're planning to be pregnant, we know how I'm going to address them. When I find out they're not and they're in the age group of reproduction, then I know what I'm going to do when I see them. And even before that, my receptionist knows what she is going to do. So if they're not interested in pregnancy, we have Bedsider. And I can't believe I'm sitting next to Bedsider. That's really great. And so we have the little cards, gives them all the choices. In all of my exam rooms, I had that and the 1, 2, 3, 4, the best practices. And so they get it from all directions. The whole premise of offering all options, I think, is real important. It's not just LARCs. It is, believe it or not, I have a few patients that use diaphragms, and they're really good at it, but not very many women are. But then we have the IUD, so the full gamut. And you try to come to each patient where they are. Some patients are not ready for LARCs. They just aren't. They've not even thought about birth control, and now you're talking about a foreign body that just doesn't sit well with many patients. But you can take them along that progression. And if you have a patient that's ready, then you're ready, and that's where I am now. When they're ready, I'm ready, and I'll take them to each step as they need to be taken. During this last few years, when we've been dealing with the CAN program, and those of you that have seen the video, I'll make it very concise, but there was a moment when I had a young lady come in to see me. It was her first visit, and we were talking about birth control, and she just didn't seem as though she felt as though there was a need for her to use birth control. She was sexually active, but that wasn't the big thing in her mind. And if she said, well, you know, if I get pregnant, I get pregnant. And I kind of looked at her and, well, yeah, but do you want to get pregnant? Well, no, I don't want to, but if I do, I do. So my question to her is, well, what do you want to do? Who do you want to be? Where do you want to go? And this young woman, about 19 years old, turned and looked at me and said, well, what do you mean, what do I want to do? Who cares what I want to do? I'm like, well, I care. That's why we're having this conversation. And she had this look on her face that I will never forget, never forget. She said, nobody ever asked me that question.
Yeah.
That's why I do what I do, because the question has to be asked. We have to give direction to our young people, many of whom don't have an adult in their life that they're comfortable with speaking with. And so for many, I'm the first person that they've sat with and had an honest discussion about what it is they want to do, where they want to go, and how they want to do it. And so if I can help in any way, I'll try to do that. I will often bring, particularly my young patients in, they'll come with their mother or guardian or their grandmother, and we'll sit and talk, and then I'll look at whoever that adult in the room is and say, well, at this time, I'm going to have you just step outside because we have to have a discussion that only the two of us can have, because that's important. And I always emphasize to all my young adults and my young adolescents that unless they're going to tell me something that will do them physical harm, I won't break their trust. So I walk around with a lot of stuff up here that I try to give up. But I think it's important for the patients to know that they can trust us and they can share with us. And so when you have a patient, I think it came up about abuse, when you have a patient in the room with you that you know has been or is in an abusive situation, you have to be able to have resources to go to in order to get them help. And it's very difficult for these young women to come in and let you know that they need that type of help. I digressed a little, but it all goes back to this whole issue of giving a breadth of information and just trying to do the things that are necessary to meet patients where they are and do for them what they need. And that's what I try to do. I'm really glad that I was able to be here today.
That was just spectacular. Thank you so much. Puts human feeling and the reality of the individual right at the center of all this. Thank you. I'm going to pose a couple of questions to this group as we did in the last panel, and then we will have time for questions from the audience. The first question I want to ask is, what gets you in trouble and how do you respond? I mean, everything that's been mentioned, at least from my point of view, is creative, it's reasonable, it's good, it's evidence-based, it has deep humanity and heart. But I also know that this field brings out the worst in people. You know, you sometimes are trying to do your best and you still get in trouble. So I would just like to ask each of you, what gets you in trouble and how do you respond? And we can- yeah,
I'll jump right in.
Please.
I'm known to speak my mind. I have really interesting patients who come to me because they know I'm going to tell them like it is. And if you don't want to hear the truth from me, you shouldn't come to me because I think that's my obligation to be honest. So I'm honest with the patient, but then sometimes if I have a mother who has decided that what I've told the patient is not the way they're going to go, we have some conflict. And I will generally say, I can't get in the middle of this. I've given your daughter the information. This is what she would like to do. You disagree with what I've recommended. The two of you will have to have that discussion, and whatever you decide, I will move in that direction.
So I think that power to decide has always been grounded on meeting our audiences where they're at. And that means that what is in Bedsider, what is in some of the other work that we do with the entertainment industry, et cetera, doesn't necessarily resonate with everybody and might feel a little out there and a little too edgy. And that can get us in trouble every once in a while. It might not be technical enough, or did we really use this language, et cetera. And, you know, it comes back to, you know, the mantra that we use a lot. And sometimes when I review content, I say, I'm not the audience. And I think that that's really important, that if we really want to touch the lives of young people, meet people where they're at, we need to recognize that. We need to do that with some humility and really listen to who we're trying to serve.
I guess I would say what probably gets me in the most trouble is, as I said for my presentation, you know, part of our focus is on non-marital birth rates and the role of marriage. So that certainly, I think, raises tension. But when we think about ensuring, you know, young people or young women understand all of their options, it's also important that they understand information about what has transpired with other young women and men and how they have achieved success in their own life. And if there is data, for example, around this series of decisions around education, work, marriage, then children in that order, 97% of the time lands you in the middle class or beyond, that should be part of the toolkit of the information that young people have. But it seems to, you know, cause tension. I mean, generally, even though we're making progress in this area, the truth is the numbers are still big enough that there are very young children being born and then being raised in environments that are likely putting our kids on a treadmill that they will repeat the same outcomes as their parents. And we just have to be honest to talk about these things.
I have a long list of things that get me in trouble. I think the first is that we're working with a healthcare system that is a big bureaucracy, that is under stress and under-resourced, and we are trying to bring this topic into the center of primary healthcare rather than just being in specialty care. And so trying to move that mountain is very hard, and there are many disincentives along the way. I think the other thing I would say is that you know, too often this conversation gets reduced down to a conversation about LARC, and it's not about that. And I think we're going to hear from the folks at Child Trends a little bit later on, and I think much of the progress we've seen in reducing unintended pregnancy, or the estimation of that in Delaware, has actually been about women choosing all kinds of other methods as well. It's just simply more access to more methods. It's not really all about LARC, and so that's an important thing for us also.
Okay. I have another question that I used to get asked a lot, and I just want to ask it of this group as well. It's always, what about the men? There'd be we'd be 2/3 of the way through a meeting, and some would say, what about the men? And I would often say, well, look, it's women who get pregnant. It's often women who do the majority of child rearing, especially in early years. And most of the birth control methods, except for the male condom, are female-centered. So it's no accident that we talk a lot about women. But they would say, yeah, but it takes two to tango. And I go, that's right, I've heard that. So I would just like to ask this group, what do you do and say with and for and about men in all of this? Do we leave them out, and they're often not in family planning clinics, sometimes they are, but I'd be interested in what about the men?
Well, I had a little vignette I was going to share, and then I said, no, I don't have enough time, but I will because you've asked that question. I had a young woman come in who we went over the whole scope of birth control, and she decided on a pill after going over everything, and she had looked at the bedside or chart, and she said, would you mind if I come back? My boyfriend's out here. Can I come back in? I know you have other patients. I'll wait. So she had to wait for a few minutes, but she came back in and he came in. And she said, would you just go over what you've gone over with me? Because I think it's important that he hear this. And I just thought that was so nice that he was interested. She wanted him to hear, and he was very receptive. And we talked about how the various methods and the things that he could do to ensure that they were effective. And he said he was going to have an app on his phone.
We get this question a lot, and I'll answer it in a few ways. We get this question a lot as well, and I'll answer it in a few ways. On Bedsider and within our materials, we have the Guy's Guide to Birth Control on Bedsider, video content, very fun, very funny. And we do work to ensure that men and young men in particular have what they need to be a part of the conversation, a part of the partnership that it requires to reduce unplanned pregnancy. That being said, going back to our audience research, we have an answer that people might not want to hear, and that is, to get to the men, you need to get to their women. That's what we keep learning over and over. Mm-hmm. And that's because men say that they find the most reliable source of information around sexual and reproductive health to be the women in their lives. And that doesn't necessarily need to be a romantic partner. It's just that they say, well, women know, I'm not going to talk to other guys about it, or, because women know more. And they're kind of right. But they also, do by and large believe that they're like, well, it's really her call. What method she chooses, things like that, that's really her call. And so those two things combined make it so that some of the best interventions we might be able to do for men is to really support women to influence men in a positive way, while also working on the longer-term responsibility component.
So this is definitely a huge area. Even in my presentation, I said, the data I showed was all focused on non-marital birth rates for women. And I said, because that data isn't even tracked, we should be collecting information related to men, non-marital birth rates, unintended pregnancy rates, to show that this responsibility is shared. It is solely not focused on women. In our own class, Pathways to Power, which we teach as the last semester of 8th grade, our boys' school, we're not yet up to 8th grade, but we'll be teaching, we'll be having that class for boys as well. The way that we frame that class is that we use the 7 Habits of Highly Effective Teens as our anchor texts. We have our 8th graders create essentially a 10 to 12 year plan about what it is that they want to achieve in their life, what are the obstacles that they think are going to stand in the way, and what are their plans to overcome those hurdles, especially in the next 12 years of their life, where they're making some of the biggest decisions that will have positive or negative consequences. We want girls to have that same sort of future orientation and plan. We want boys to have that same future orientation and plan. I mean, even in this room, I'd probably say it's about 90% women versus men. So just generally, guys are not part of this discussion, and we really need to be.
So as part of the regular training that we do that has taken place all across Delaware and the other states that we're working in, it's obviously we focus on dual method use. It's very important. There are methods that are great for reducing unintended pregnancy. There are other methods that are really important for reducing STIs and STDs. And so what many people in this room may not know is that there actually are 12 steps to putting on a condom appropriately. I would like to do a little pop quiz, but I won't do it here, about how many also know. But it's important to know how to do that, even that appropriately and well.
You know, I just remembered years ago there was an area of research in demography on this issue of intendedness, unintendedness, which, as Belle mentioned at the beginning of this meeting, is a question asked of women at the time you became pregnant. Were you planning? In which, in a small group of people, they were able to also ask the male partner, was this pregnancy intended? And there was quite a bit of dissonance between what the women reported with regard to intendedness and what the men reported with regard to intendedness. And I've often just thought about that and remembered it as one more complicating factor in getting this all lined up. I have another question I'd like to invite you all to speak about. In essence, the question is, how can all of us here, not just you all in your programs, but how can all of us bring family planning in from the cold? And by that I mean, how can we, this field, be more included and supported by all these other fields that we work so closely with and support so warmly? You know, Head Start, early childhood education, home visiting for at-risk families, you know, this whole social services network that, you know, they're right next door to us, and we always say if we do our job well, it will help you in your work. But my experience has been that there's a separation between all the good social welfare stuff, maternal and child health, all that good stuff, cement wall, and then family planning. I don't know, we're too hot to handle or something because we're not all working together. I mean, I think, for example, wouldn't it be amazing if the Title X program were reauthorized and there was a big hearing, and most of the people testifying in favor of family planning were from these other agencies, not just family planning providers, who, of course, their funding is at stake. But why don't we have the housing people and the job training people and the child care people all saying, this work that Title X supports is critical to who we see down the road? So I would just like to invite anybody here, or when we get to Q&A with the audience, how can we bring all of these together, and in particular bring family planning in from the cold?
I mean, one thing that I would say, and I mentioned it in my presentation, in the world of education, if you're looking at education data, you can see information sliced and diced by race, class, gender, geography, but you almost never see that data sliced in terms of family structure. And one of the reasons I am a big proponent of including that as a new metric or a new category of measurement is that I think we would start to see over time that there is more than a correlational relationship between family structure and ultimate academic outcomes for kids. We're already seeing in healthcare, National Center for Health Statistics, they put out reports where they have 7 different categories of family structure, and they show what the relationship is to long-term health outcomes for kids. If you show relationship to family structure in terms of incarceration data, poverty, it's pretty massive. It's pretty, some would say causal, I would say more than correlational, but that's important data that if we were to make family structure a common metric of measurement across sectors, I think there would be more of a realization that family planning is a critical element to strengthen the family structure that then has such a huge relationship to all these other social outcomes that we're all fighting to address.
Just to add to that, I think that it's measuring on the front end and the back end, but it's also putting performance measures in place that are integrated in nature.
Yeah.
Right? Because what gets measured gets done. And having worked a lot of my career in an educational setting as the health person, I know that, and having talked to a lot of administrators, they will say, yeah, it's such a priority, but this is what the state's asking us to do, and this is what's being reported. So I think in addition to collecting the data to make the case and to make the case in terms of outcomes, I think it's also important for us to really think about how we create blended performance metrics so that we are all incented to work together.
Yeah.
it just strikes me that the whole conversation about opportunity in this country really begins after children are born. We say this child is here. What do we do now to make sure this child achieves its full potential, which is a really important conversation to have, of course. But we haven't, Sarah, to your point, included the conversation we're having here in this room. I do think that Brookings has done an extraordinary job of bringing family planning into the opportunity dialogue, and it's events like these, in fact, which I think go a long way. I do think that it struck me in my previous job when I was working at Opportunity Nation. The College Board put together a panel on one of these events. There were 8 young people between the ages of 25 and 30, just talking about their life story. And long before I'd ever even thought about Upstream, 7 of the 8 began their stories with some version of, well, I got my girlfriend pregnant and this happened, or I found myself pregnant and this happened. I mean, just unaided, just that topic is there. So it is real. It is a part of the conversation, or it should be more a part of the conversation. And I think until we stop thinking about opportunity exclusively as starting in the province of once this child is here, we're not going to make the kind of progress we need to.
And friendly amendment to that, it's actually once there's a positive pregnancy test, there's all this emphasis on prenatal care, which I love. I get that. It sort of starts with prenatal care forward, early intervention, support to high-risk pregnancies and so forth, but you can't back up that little bit of it.
Can I just add
Please.
No, finish up on your thought.
You go ahead.
You're asking how to get other people to come and testify when we need to do that. I think of some of the things that done at a local level, going into a correction institute, or going to the girls' reform school and actually giving classes there. Done that. Going into my church and giving a class there. Done that. But I don't think many of us have thought about when time comes to go back to those same places and say, we need your help now. This is what we've been doing with you. Can you not come and support us? So I think we have an ask.
I just add just one last thing, which is that I do think that it's possible to both deliver best-in-class contraceptive care and not in a non-coercive and entirely voluntary manner. And I think that's a middle ground that actually can work. Mm-hmm. But until we sort of recognize that, and this is going to continue to be sort of such a topic outside of that.
Too hot to handle.
Yeah.
And just one last thing. Yesterday, I presented at the Beulah Church on East Gun Hill Road in the Bronx on this topic. And what was just really interesting, there are many allies within the faith community that are given the permission to have these conversations, and sometimes we don't invite that community in. I think that would be another huge population to really tap into.
Very helpful. I think it's time to invite questions from the audience. We look forward to them. Am I the chooser? Who has a microphone? How about right up here in the leopard print dress?
Thank you so much for your presentations. My name is Caitlin Thistle. I work for USAID, and I work in international family planning programming. More specifically, I work in the research division at USAID. So I have 2 questions. The first for Ian. You talked about births outside of marriage, and you talked a little bit about a class that you have in your charter school. I would like to hear a little bit more, and I wonder if you talk to your students about body literacy, about puberty, about fertility, and how that comes about during puberty. And then my second question is to Ginny. I love Bedsider. When I first discovered it, I shared it on my Facebook page. I shared it everywhere. And I got some pushback. And so one piece of pushback that I got is on your chart of family planning methods where fertility awareness is. It's very, very low. And in our international programming, we have disentangled the rhythm method from things like the standard days method. So I appreciate hearing that you are constantly revising things because we just published some research from a clinical trial of the dynamic optimal timing method, which is an app. And it's 95% effective. And it's just women tracking their cycle and abstaining or using a condom during days when they are fertile. So I love Bedsider. I love that it's client-based. And I think there's a little bit of tension in the communication of the effectiveness of methods, because we do know that there are some fertility awareness methods that are highly effective. So when we put them off to the side, like very low effectiveness, I think we do a disservice to women for whom that method is going to be the right method. So sorry, there's not a question there. There should be.
In terms of so our schools go through 8th grade, and so we do some of the things you just talked about in terms of fertility, body awareness. Those are things that we teach pretty much in our hygiene and sort of our social worker advisory. So that is intact, and I think something that's relatively normal in most schools. We think we've gone one step further to create a new class called Pathways to Power. And there the frame isn't exclusively around sexual behavior. It's really around this idea of creating a plan for your life, right? Of which sexual activity is a component, but there are other key elements or other key rites of passage that we want to ensure, again, our graduating 8th graders know about before they embark upon the next 12 years, high school, college, and the first 4 years of young adulthood, because the decisions that they're made in those 12 years can have fundamental impact, so positive or negative. So that's why, again, the data associated with the success sequence we think is so empowering, because it's not a prescription, it is a description of what other young people who have faced series of decisions, these were the outcomes. We did a presentation last year related to the economic success of black men in America that basically mimicked much of the data that came out of the original success sequence data that basically said, hey, big story, there's actually a thriving population of middle and upper class black men. So the question was, how do you get there? How did that group get there? Turns out that education, work, marriage, then children was usually a common set of decisions that this group had made, in addition to elements related to church participation, some related to military involvement, and then this last idea, personal agency, that they felt that their individual decisions had greater influence over all the forces that might be arrayed against them. So the class that we create in Pathways to Power is all about that. It's all about creating this plan for your life and learning from the experience of those who, again, came from very similar circumstances, but were able to overcome the inevitable challenges that our kids are going to face.
And I'll just say thank you for your feedback, and we are constantly improving and reinventing. You will find some more recent content, actually, if you go to Bedsider on fertility awareness for our consumers. In terms of our clinical materials, we work in partnership with UCSF Bixby to constantly update those materials. That process takes a little more time based on new data that are available, but we are looking at revising them in many ways based on learning. So, but that cycle from just the perspective of really getting it through different review processes, et cetera, takes a little longer.
Other questions? Let's see, in the red shirt here.
Thank you very much, Larry Checkow, Senior Advisor to Serve USA. Family planning. How do we get family planning not to be anti-religious? What role does religion play in your work? We're seeing what's going on with Planned Parenthood, for example, and the struggle it's having to do exactly the kind of work that you want to do. Look at what's going on in states like Alabama, Missouri. So, it sounds like you're fighting a battle here with religious institutions. How do we get beyond that to show people that this is your future? You keep saying it. These decisions that you make are going to go right not only through your future, but all the generations that follow you. How do we get that message through to people?
Well, in my case, literally, I was at a church yesterday because I think they're more receptive audiences that we might imagine. Because certainly these parishioners yesterday were very concerned. I mean, we were right in East Gun Hill Road in the Bronx, where these issues are very prevalent. And so the pastors and leadership there were very interested to hear how we're constructing this course for our own kids in our schools. And so I would not assume that there's opposition. I think there's a lot of opportunity for collaboration.
Other questions in the white shirt?
Hi, my name's Isabel, and I'm from the UN Foundation. And I'm really curious if any of you have explored telemedicine as far as, whether it's in an OBGYN practice or, with schools and bringing access, or just online and providing resources.
Sure. We actually work pretty closely with the emerging telehealth companies that are offering online prescribing as well as deliver to your door services for most hormonal methods of contraception. There's actually a directory as well as some editorial content on Bedsider to really educate our audience about those resources. One of the things we're learning is that while it's an amazing option, it's not yet democratized. Most actually the companies would love to democratize it, but given for a lot of different reasons, it's usually pay to play at this point in time. And so that is still an access barrier, but for those women who do have insurance, and it's a great option. It eliminates, transportation costs, and we're working closely with them, and we see a real opportunity actually to really address some of the access barriers we've all talked about with these companies emerging.
I think we have time for one more question if there's one. Mark Hathaway?
Thank you very much. This could be addressed to many of you, but I'm going to direct it more towards Mark. I'm wondering if you could talk a little bit about the upfront costs and how you calculate that in a place like Delaware or other states, and then how you trend down and transition to the sustainability of, weaning yourselves out of a state.
Just to add just a little more context to Mark's question, one of the things that we found, which is exciting, is that when you really approach this work from a systems perspective, really as Dr. Rattay said, everyone from the sort of the front desk staff through the chief medical officer, it really becomes embedded in practice, and so it just becomes the way care is offered, and it's not about the individuals there; it's really about the entire system. And so, in Delaware, when we started back in 2014. Really grew to a staff of really almost 20, and primarily providing quality improvement and training technical assistance across the healthcare system, really in public, private, hospitals, inpatient, outpatient, really any place that women get their care. And now the vast majority of the state is in what we refer to as sustainability mode, which really is that we're no longer delivering active care, but really we're monitoring and we gather data to allow us to ensure that women are getting same-day access to the full range of methods with great counseling. And as a result, our staff is actually beginning to actually be reduced because there's simply no need for us to be there. Women are getting asked about their pregnancy intention, they're getting great experiences, and we have ongoing data supporting that. And so from a budgeting perspective, there is this ramp down, and to the point where pretty soon we will be essentially really ending the work. There's just no reason for us to be there, which is exciting from both sort of a sustainability point of view and obviously also from a cost point of view, because we're not going to. There are existing insurance flows. Dr. Rattay spoke about some of the new legislation that ensures that even uninsured women will continue to get access, and that's just sort of built into the system going forward.
I think we're out of time. Will you join me in thanking this wonderful group of panelists?
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.